All right, we're recording now. Hi, everyone. Welcome to this webinar of Cancer ABCs. This is a result of the Prostate Cancer ABCs conference that was supposed to be in the Villages, Florida in March 2020. But we're all dealing with a pandemic right now called coronavirus, so we've turned everything into webinars. This is one of the many webinars we're doing in lieu of the conference. So we're going to talk about PSA rising on hormone therapy today. That's a very broad subject, but we're going to give you some basics and then do some discussion and then talk about even how coronavirus, and which is also called COVID-19, is affecting decisions and thoughts that you're having right now. My name's Jan Manwright. I'm the Executive Vice President of Cancer ABCs. Thank you to Joel for hiring me. I do this because my husband was diagnosed 20 years ago with a PSA that was over 7,000 and bone metastasis almost everywhere. But it's a long story, but shortened version is I got very involved and he lived for 13 years after a PSA of 7,000. So if you catch any message today, I want you to catch that, and I will always argue that the most important part about his cancer was that we stayed involved. I will argue that's even more important than the Gleason score. Others may disagree, that's okay. I did learn that as I developed better questions, those better questions got me better answers, and that was a big part of keeping him alive for so long and turning his metastatic prostate cancer into what I would call a chronic manageable disease for 13 years. Joel, you want to introduce yourself?
Sure. My name is Joel Nowak. I am one of the co-founders of Cancer ABCs, and the reason that we started Cancer ABCs has to do also with my own personal history. I am a cancer thriver with 5 different primary cancers. One of those cancers is metastatic prostate cancer. I have been metastatic with prostate cancer for 13 years, and I am very much here. I am very much alive. I'm a healthy person despite having 5 cancers, one which is metastatic. And I think that it has to do with a lot of what Jan has mentioned as to how she worked with her husband, and that is that I've stayed involved. I got to know my cancer. I learned about it. I got involved with my doctors and never let go. That's the way I've been conducting myself, and it's what we hope at Cancer ABCs to help you be able to do, to make better questions, to stay involved, to know your cancer, and do what's called shared decision making, which is something we're going to talk about later on in this webinar.
Joel, how many years have you had prostate cancer that's metastatic? Good message.
13. I've been metastatic for 13 years, and I had been diagnosed 5 years prior to my knowing it was metastatic. I had surgery 5 years post-surgery. I had what's called a prostate cancer reoccurrence. My PSA came back, even though I had no prostate gland. I should not have had a PSA, but it came back. It roared back, and got up to be 80 by the time we discovered it and started treating it.
But it's been 13 years metastatic, dealing with it and turning it into, again, what I like to call a chronic disease. I've heard some.
It's absolutely a chronic disease.
Okay, so that's a great message. I want everyone to hear that. So I want that to be clear, truthful encouragement to keep you involved in your care. So I want to talk about how we're going to do webinars and how we're going to help you. Neither one of us are medical professionals. We are advocates. We are educators. But we cannot give you medical advice. We cannot advise you a treatment. We can advise you what to ask your doctor. We can advise you what to research. We can advise you what medical records to ask for. So those are things we can do. We will not give you medical advice, but we will most certainly prepare you to ask the kinds of questions where you can get the shared conversation advice that you're looking for. Our goal is to help you understand your own situation better. Every cancer is different. Every prostate cancer is different. Different Gleason scores, different presentations. More and more we're getting to different genetics. We'll come back to that later. But it's just everybody's a little bit different, and that's a really important message. I hope that encourages you to actually pull out those medical records and to read them and look up the big words and ask some questions. We want to help you understand risks and benefits of different treatments and tests. That is the essence of making a decision. There's two columns. One is risk and one is benefit. Risk is basically side effects and or cost or anything else that is a problem for you, mostly side effects. Benefit is cancer response. So, and keep in mind that you can have a cancer response and maybe they're not calling it cure, but that doesn't necessarily mean that it's life-threatening. Because as Joel and I just described, my husband had metastatic prostate cancer for 13 years. Joel's story, his numbers are the same, metastatic for 13 years, but able to keep it contained, controlled, and turn it into what we like to call a chronic disease. So, better questions will always get you better answers. Shared decision making is actually a medical term. Your doctor knows it. I would write that down and would keep that phrase. So instead of telling your doctor that we really want to be involved in my husband's treatment, I personally would say we'd really like to do shared decision making. There's something about using a term that the doctor is familiar with that can really make them listen a little bit more. And it also suggests that you've done some research and maybe he knows that you now maybe have some better questions. I don't know. But I found that it works. And you can actually Google shared decision making. And shared decision making is actually part of the Prostate Cancer Guidelines for AUA for clinically confined, newly diagnosed. The whole first section is shared decision making. So your urologist not only knows what it is, but is being advised to do it with you. Some of you are with a medical oncologist. We can talk about that later too, but shared decision making is my point. So I want to thank our sponsors today, Janssen Oncology. They are the maker of Zytiga and Erleada. You hear us refer to those drugs in this webinar, probably briefly. But if you ever want to look up a drug, learn to go to thedrug.com, Zytiga.com, Erleada.com. Dendrian is the manufacturer and maker of Provenge, which is an immunotherapy. So you can find their treatment at provenge.com. Bayer is the maker of Nubeqa and Xofigo. So if you wanted to look up those treatments, and we'll get into this more later, you could go to nubeqa.com or Xofigo.com. I'm sorry, the words, I have some funny letters in them, but we'll spell them a little bit later for you. Astellas and Pfizer are the makers of Xtandi, and you can find information at xtandi.com. Our other sponsors are Exact Sciences, who makes ARV7 tests, which tests for androgen receptor sensitivity. Foundation Medicine, who does next generation sequencing, which is genetic sequencing of tumors. Blue Earth, who is the manufacturer for the Axemin PET scan, which is FDA approved for prostate cancer recurrence after treatment, PSA recurrence. And then MyEvent, who has a drug in the pipeline, and Progenics, who has imaging in the pipeline. So let's get into, we're going to do some definitions, some discussion, and then some shared decision making. So let's get into just a quick definition of hormone therapy and hormone therapies, plural, and some of the words and what they mean. I'm going to turn it over to Joel to go through the next two slides.
Yeah, thank you very much, Jan. So usually when one has PSA rising after primary treatment, the usual first step is to do what's called hormone therapy, also known as ADT. Now, ADT does one of two things. It either blocks the production of the androgens, testosterone, from the body, and the androgens are what actually, for a lack of a better description, feeds the cancer. The cancer uses the androgens to grow with, or either interferes with the ability of the androgens that are produced by your body to interact with and get into the cancer cells and feed them. So the goals of hormone therapy are to reduce the production 90% of the androgens are produced from the testicles, and the first line of androgen deprivation therapy or primary deprivation therapy produces or reduces and hopefully stops the production, and that's about 90% of all the androgens that are produced. And the other goal, depending upon the drugs that are being used, is to block the action of the androgens on the cancer cells. And then we have secondary or the newer drugs that not only do, depending upon the drug, blocks the androgens from the testicles, they also block the production of the androgens throughout the body, usually from the adrenal gland or sometimes from the cancer cells themselves. And yeah, go ahead.
I want to go back real quick. You said the usual first step after recurrence from local therapy is hormone therapy, but there's also options there's more than one option, right? So sometimes there's salvage radiation, sometimes, so there's some other options, but this would be the likely systemic therapy.
Right.
Okay.
And oftentimes, even with salvage radiation, it may be coupled with hormone therapy.
Right, but there are options. This is a common one, but it's not always the first step.
Right.
Okay.
And the other thing, you know, I mean, hormone therapy is used for other things, and probably now more in COVID era, it's some urologists are using it in order to delay primary treatment surgery because they don't want to bring somebody into a hospital. But that's not really the topic of this, but you'll see it used that way. And also in primary therapy, often hormone therapy will be used in conjunction with radiation therapy for primary treatment because it does seem to enhance the effectiveness of the radiation as well as shrink the size of the prostate gland itself.
Right, and that would be for newly diagnosed patients. So
correct.
Yeah. I have one question, Joel. Randy asked, did you have a prostatectomy?
I did. I had a prostatectomy, and as I mentioned earlier on, 5 years after the prostatectomy, in which I had no PSA, PSA came back because obviously, despite having the gland removed, there had been obviously a release of some cancer cells prior to the surgery, or perhaps there was a little bit of tissue left behind. That does sometimes happen. And it took 5 years for the cancer to decide that it wanted to reinvigorate itself and start growing. And that does happen. It happens in about 1/3 of men who have primary or first level treatment. They will have a reoccurrence. And it doesn't matter what the treatment is, radiation, surgery, that 1/3 number seems to be a pretty stable number.
Okay, thank you.
So the next is, how do we actually achieve hormone therapy, or how do we do it? The original way was through surgery, which was called orchiectomy, where we surgically removed the testicles. There are still men in the United States who do use this therapy. It's less expensive than doing drugs or injections, but it is not reversible. Once you have an orchiectomy, you cannot be reversed, where there are different ways with the drugs of stopping it and starting it. We'll talk a little bit later about that. So that's the surgical way. There are still people who do it. And then there are other drugs like Lupron and Eligard. They're referred to as luteinizing hormone releasing hormone agonists. And what they will do is stop the production of the androgens from the testicles, as another drug called Degardelix or Firmagon, which also halts the production. They work through a little different mode of action. They work at different speeds. And it's something that you would ask your doctor to talk about what the merits or pros or cons or risks or rewards of each of those drugs. But again, what they do is stop the production of the androgens from the testes. There are some men who also use estrogens, and estrogen will also help stop the production of testosterone or androgens. You need to find a specialist who's going to be able to work with you on doing that. There aren't a lot of doctors in the United States that do use it. There are some pros and cons that you should discuss with your doctor on that. And then there are the drugs that block the ability of the cancer cells, as I said earlier, to actually be absorbed or utilized by the cancer cells. And those drugs include, at primary level, most commonly a drug called Casodex or bicalutamide. Usually in the United States, they're given at 50 milligrams a day. It's a pill. It's taken once a day. And there are, in the more advanced diseases or more aggressive diseases, we now have enzalutamide, Xtandi, apalutamide or Leta, and darolutamide, Nubeqa. And those drugs are anti-androgens, and they also, were used both initially in certain cases and certainly once hormone therapy itself has failed.
And did you mention Zytiga?
Did I mention Zytiga? I did not mention Zytiga. I should have mentioned Zytiga. Zytiga, like the luteinizing hormone releasing hormone agonists or the LHRH antagonists, stop the production of the testosterone, but they stop it not only in the testicles, but they also stop it from the adrenal glands. Remember, I said earlier that 90% of all the androgens are produced from the testicles. The other 10% come from the adrenal glands. And unfortunately, these cancer cells, as they progress and they kind of learn how to develop their own source of androgens, and they can actually self-feed themselves. And Zytiga, which is taken along with prednisone, will halt the production of that. So you have a much better basically much better hormone blockade.
So I think I want to pause for questions. That was a lot of information about hormone therapy. Does anyone have questions about my story, Joel's story, or these two slides? We definitely are discussion oriented, so don't be afraid to type one in the chat box or ask a question.
May I ask a question?
Sure, of course.
Did you, is the most common ADT option that is chosen is the LHR, LHRH, and did you mention that the other pill options are usually not primary treatment, but maybe supplemental?
Secondary, I would call them. Yes.
Secondary.
Yeah.
Okay, secondary.
I'll answer that and I'll let Joel take it. Yeah. So usually, honestly, when you're with your doctor, let's say, and hormone therapy is brought up, or when people are talking about hormone therapy, it usually means these shots, these injections. That's the most common.
Thank you.
Yeah.
Thank you.
Yeah, and I would add that
thank you.
Using these injections, there's a thing called the PSA flare. So what happens when you start these medications? But basically, if you go back to the earlier slide, Jan, for a moment.
Okay, and I want to come back to that question though.
Yeah.
Okay.
So what I have here, there's the picture. If you can see it, you may not be able to see it. Is that the pituitary gland in the brain is actually sends signals to the testes or the testicles to create or manufacture the androgens, and this is a normal feedback.
Okay.
That goes round and round. And what happens is these drugs break. They actually don't work on the testes or the pituitary gland. They actually break this feedback that goes back and forth. And what happens when you break that feedback, the testes kind of looking around for a signal, should I be manufacturing androgens or not? And when they don't hear it, they sometimes go into kind of they kind of hyper produce the androgens, and they literally can flood the body with androgens. And of course, that's like inviting your prostate cancer to Thanksgiving dinner, a feast. And so you can see a jump in the PSA, and that's referred to as a PSA flare. And it's not particularly something you want to do, because what you're doing is reinforcing and helping the cancer to become a little stronger. So what usually should happen, and you can ask your doctor if they don't suggest it to you, it's a really good question. Why, should I be taking a drug that'll actually be an anti-androgen, a drug that's going to block the ability of the cells to absorb the androgens. The most commonly used drug at that stage is going to be the Casodex or bicalutamide, same drug, generic versus brand name. And that will actually stop that flooding of androgens being able to access the cells. So you stop that PSA flare. There are exceptions that now with some of the newer drugs that they are approved even in the stage where there's castrate-sensitive cancer for aggressive cancer, Gleason's 9 and 10, and that's a separate conversation. But
Yeah,
they
that's
could
a
be
separate conversation. Yeah.
yeah, and the other thing is that there is this other drug which is also an LHRH, and that's an agonist, and that's the Degradelix or the Firmagon that Jan has highlighted. That drug works much more quickly. It's a different mode of action than the Lupron or the Eligard, and you don't get this PSA flare. You literally become castrate within a couple of days as opposed to, say, 30 or 40 or 50 days.
Okay, so let me simplify real quick. For the first shot for hormone therapy only, and that's what these are right here, the injections. For these, when you have the first shot, there is a phenomenon called flare, where your PSA temporarily goes up before it comes down. For some men, that can be dangerous because the testosterone goes up before it comes down. To my knowledge, there's two ways to prevent that. One is to use an antagonist, is to ask for Degradelix or Firmagon, and the other is to take bicalutamide or Casodex before the shot. Most people say 10 days to 2 weeks. So I just want to simplify that. That's the first shot only. After that, the reaction does not occur. So I want to come back to the discussion of different types of hormone therapy. And yeah, you're right. The anti-androgens here are what you would use if your PSA was rising on this, right? PSA rising on hormone therapy, we're referring to the shots. And one of the options is definitely to consider one of these drugs. Another option is Provenge, which is Sapilus LT, but we're not going to get into that too much. But it's definitely an option. We're going to be doing a webinar on immunotherapy next week. So we'll definitely be talking about Provenge in detail then. And that's Friday, May 1st at 3 o'clock with Dr. Charles Drake. But we just wanted to define hormone therapy for you. Yeah, go ahead.
Just a little clarification, Jan. So now Xtandi and Zytiga with prednisone can be used. They have been FDA approved for castrate-sensitive. Newly diagnosed, yes.
Talking about PSA rising on hormone therapy. Okay. Yeah, metastatic or non-metastatic. Okay. Yeah.
Right.
Yeah.
Okay.
Yeah. So, okay, I have another question. Let's see. Jan told us, yep, that's me. The specialist is a medical oncologist. Joel just mentioned a specialist when talking about hormone therapy. Is there a name for that specialty? Do you want to answer that, Joel, or do you want me to answer? I know who this is.
I didn't follow the question, so you answer it.
So there's at least two different types of doctors that can give you your hormone therapy, whether it's, and again, we're referring to the shots, the LHRH antagonist. One is a urologist, two is a medical oncologist. Usually radiation oncologists, which is a third type of doctor, do not give it, usually. There's some exceptions to that. I've heard that in teaching hospitals and academic institutions like universities, sometimes they do. So there's two doctors. So no, there's not another specialist that gives hormone therapy in prostate cancer. It would be either the urologist, whoever owner is, OWN. You get some background noise. I need you to mute yourself. OWNEX. Thank you. Yeah, there's two doctors. One is a urologist, two is a medical oncologist that give hormone therapy. It's namely the injections, these shots. When it comes to the secondary hormone therapy, which is what you would take when your PSA is rising on hormone therapy, which is the title of this webinar, when it comes to these, sometimes a radiation oncologist can write a prescription. That's different. That's just a prescription as opposed to having an injection in-house and a nurse to administer it. So that could be an exception. Any other questions?
Jan.
Yeah, go ahead, Gary.
Yeah, I do have, just to the point you just made about the two different doctors.
Yes.
For instance, I'll be going to a radiation oncologist.
Yeah.
So if I have ADT treatment, are you indicating that I'll probably end up with either a urologist or a medical oncologist to give me the ADT shot?
Good question. There are some exceptions. Did you tell me that you're going to a place in Sarasota?
No. What I said was I've got a May 4th appointment with a doctor at the University Hospital in Cleveland.
Okay. Yeah, so I'm not sure.
But it's probably.
Yeah.
Okay, so I just need to ask him.
Yep, just ask. Again, because you're at a hospital,
okay,
maybe the radiation oncologist does. In the community setting, like we just went to a clinic, they didn't. So yeah, you're welcome.
Okay, thank you.
Of course. Anyone else? Okay, then I'm going to move on to the subject of hormone therapy and coronavirus, or hormone therapy and COVID-19, because I think this is a really big question right now. If you guys have seen these ads on TV, this is done by the Ad Council and it's put out by the CDC. CDC obviously is one of the most important and best resources for information on COVID-19 or coronavirus. But they talk about, actually the risk is not in actually contracting the coronavirus, but from having severe illness with it. So they talk about several things that put people at greater risk. One of them is being age 65 or older. Another is having a compromised immune system. Another is having diabetes. But one of their slides says this: people undergoing cancer treatment. So since there's so many different types of cancer treatment, I thought I really wanted to address this because I don't think, I mean, in general, I suspect they're talking about chemotherapy or other treatments that tend to compromise the immune system, but I don't know, but I'm really suspecting that. What we do know is we've got several experts who have been telling us that hormone therapy in general, which are these shots that we've referred to mostly, but also the pills, they do not compromise the immune system. They are not immunocompromising. We've had a couple of experts even ask the question and propose the idea that maybe in certain times they help boost the immune system. Now, again, I'm not a doctor, but where we're at right now with coronavirus and COVID-19 is we don't have big trials. We don't have level 1 evidence. We don't have proof. So we've got a lot of our best experts discussing some of these key issues, and sometimes that's our best information right now. And they'll be working off of, smaller studies, their current knowledge and their current experience. So I think that's really important. I think everyone who has cancer worries about coronavirus. Am I at risk for getting it? Does my treatment make me at greater risk for getting it? So, Joel, you want to comment on that a little more? And then I'm going to play a video where Tanya Dorff talks about this.
Why don't you just go ahead and play the video?
Okay, let me do that. So, Prostate Cancer Foundation has been putting out some great videos that are really helpful. And now I'm going to try to find it. Look at there. Where do we go? Oh, here we go. With these experts, discussing what they're dealing with their patients, how they're doing things different. What you have here on the right is Alicia Morgans. She's a medical oncologist, and she's interviewing Tanya Dorff on the left. And Alicia is in Chicago, Tanya's in California. But Alicia's asking her some of the common questions that patients have about, like, hormone therapy. So I want to play this response for you. I think this will be really helpful. And then I can email you the link to this video.
But for those patients who are just out in the real world, those patients not on clinical trial, what is your guidance for them in terms of COVID-19? Are they at increased risk? And maybe are there certain stages of prostate cancer where they would be at higher risk than other stages? What are your thoughts on that? So that's a common question I get from my patients, and I'm sure you do as well. So the nice thing is that hormone therapy, things like the Lupron type injections we give, or the androgen blocking pills like enzalutamide or abiraterone, that those don't increase a patient's risk. They are not immune compromising. I think patients get a lot of reassurance out of hearing that. The bigger issue is, reducing number of visits to the clinic. So we're doing telemedicine for someone on abiraterone, for instance, where you need to check the labs every month for the first few months to look at electrolytes and liver tests. We can do that using a local lab and then a telephone visit or a video visit. We're also maybe using more of the 3-month or 4-month injections of LHRH therapy instead of the monthly to try to keep people from needing to come back to the cancer center. So we're making those types of choices, but really on a case-by-case basis, we call the patients and talk to them, or when they come in for their injection, we talk to them about, switching to a different length of treatment of their injection. Perfect.
Yeah.
So
I want to make some comments. So, in here we're hearing that the hormone therapy does not compromise the immune system.
correct.
And I think that's important. And I will also let you know that I have had conversations with Dr. Chuck Drake, who is going to be doing on next Friday, not this coming Friday, but a week Friday, a webinar with us on immunotherapy. Dr. Drake is probably one of the foremost experts on immunology and prostate cancer in the world. And specifically, I asked him if hormone therapy affects the immune system, and his response was that the only evidence that we have is within animal models, not people, but in animal models, anything that breaks or changes or modifies the androgen signaling pathway, which all of these drugs we spoke about do, will actually, with animals, enhance the immune system. I'm not saying that he's suggesting that it does it in people, but we have that evidence in animals, so it's consistent. So I think it's a concern that perhaps many of us do have who are on hormone therapy, and it should give us some relief that we're probably not going to make ourselves more vulnerable.
That would give me great relief if it was me. Any questions on that? I think that's actually great news, that hormone therapy doesn't compromise your immune system or put you at greater risk. And some experts are questioning whether it might boost your immune system a little bit. So I love it when the experts are questioning things. It's always interesting. Questions?
Jan, can you hear me?
Yes,
Dennis.
hi, Dennis. Yep.
Hey, how are you? Yeah, a couple of them. I don't know if I'm going to saturate the system, but
That's okay.
why is it, it's at least in South Florida,
Yes.
Lupron seems more commonly used than Firmagon or Degarelix?
Great question. I'm in Southwest Florida, so I don't honestly know the answer. I do know where I live, Eligard is also used. That does come in a 1-month shot. It's a shorter needle. I think with Degarelix, which the other name is Firmagon, it has to do with Medicare coverage, has to do with cost to the doctor, has to do with which brand the doctor is using. If you had a question about that, let's say you wanted to use Firmagon or Degarelix, I would go to firmagon.com, I mentioned this before, and find a phone number and call them up and ask them if they had a doctor in your area who administered that drug. That's how I would find a doctor. Go ahead, Joel.
Yeah, I would also add that in my experience, that Firmagon is not the most commonly used drug in not only South Florida, certainly that's the case in the Northeast of the United States. I think not only your expense is part of it, I think also the fact that it's a 30-day shot, and you have to be very obsessive about getting that shot every 30 days, where with the other drugs, the Lupron, the Eligard, you can actually give a 30-day shot, a 60-day, a 90-day, and even a 6-month shot. So it means you don't have to go back to the doctor as often. And I think that's the case in normal times. And certainly a lot of doctors, when we speak to them about how the COVID virus has changed their practice, they're using longer acting shots so that people don't have to come in and expose themselves or their staff to interpersonal connections. So I think that's common, and I think that those are the driving forces.
So
Okay.
Dennis, how does that apply to you? What is your question specifically? Are you getting ready to start hormone therapy?
Well, that was the follow-up. Yeah, I just took my first Lupron shot
Okay, got it.
2 weeks ago, but prior to that, this was the thing. I had a spot that was shown up on a PSMA at L1, and it was
Got it.
radiating.
Let
It
me
was
pause
radi-
there for a minute so people understand. PSMA is a PET scan that's in clinical trials right now. It looks really interesting, but it's in trials only. And
Right.
when he says L1, he means in his spine and his lumbar spine and the lumbar one. So you found
Right.
a metastasis on your bones.
Right, and that
Okay.
that was the only spot that
Okay.
was found.
Yeah.
They radiated it, they killed it, and the doc thought that following it up with Firmagon for 6 months would enhance the effectiveness of it.
Yes. But
Well,
you couldn't find Firmagon.
I'm sorry?
You couldn't find Firmagon.
Oh, yeah, I did. And I did. They were giving me Firmagon for 1 month at a time in both New York and in Florida. So that worked out okay.
Okay.
But then we stopped it, and it was good for 6 months, and then the PSA crept back in.
Got it.
So now what we started is, I guess that brings up another question, is intermittent use really effective in extending the usefulness of any of it?
Two questions. I'll let Joel answer the intermittent because that's what he's been doing for years. So you're asking the right person. But so did you say you just started Lupron 2 weeks ago?
Right. So I'm wondering how long before the PSA should drop to zero. I did take Casodex for a week
Oh, you
before
did.
that.
Okay, so that addresses the flare issue that we talked about 10 minutes ago. So
Yeah,
for
but only 1 week.
Lupron shot, yeah, so that's good. So how long does it take for the PSA to drop on Lupron?
Yeah.
There's a couple things. One, it depends on usually how high your PSA was to begin with, how robust your testosterone was. Do you know what your PSA was when you started?
It was about 3.5.
Then it might drop very quickly, and it might get close to zero pretty quickly. I would be asking, just use your own curiosity. Ask the doctor. I think Medicare might pay for a PSA every 3 months, but there were times with my husband's care where we were taking it more often because we wanted to measure a response with a treatment. We wanted to know how well the treatment was working. So if Medicare doesn't cover, ask how much the cash price is because it's a cheap test. It might be $50, might be 40. So ask for a PSA when you want it and have that conversation with your doctor.
And Medicare's pretty good in covering it, though. I'll say that.
Yeah, let me jump in because I want to first backstep a little bit because I want to define some terms. So you said that you're on or you're doing intermittent, and let me just explain what intermittent hormone therapy is versus continuous, because those are the options. Continuous, originally when hormone therapy was used, once you went on hormone therapy, you were on it forever and 3 days afterwards. You never stopped it. And then because it does have significant side effects, or it can have significant side effects, some people started saying, well, I'm castrate. I've been castrate for a while, which is the goal of the hormone therapy, to make you castrate so that you can't feed the cancer. Maybe I don't want to continue, feeling the side effects, so I'm going to stop for a while and let my androgens recover, let them come back so I can feel better. And then when my PSA starts going back up again, I will go back and start the hormone therapy again. And that's referred to as intermittent. In other words, on and off, on and off. And that's what I've been doing for the 13 years. I go on and off, on and off. There is some research that's conflicting here as to whether one is better than the other. So there's some really large studies that were done that showed that people on continuous hormone therapy had a longer life. In other words, their survival was longer than people who were on intermittent. And there are also excellent studies that showed that the survival difference it does not exist. There is no survival difference. What we do know consistently, and certainly I can attest to, is that when I'm on my off time, my quality of life is much improved, as long as, because my testosterone levels have improved, and so I don't have the side effects. That's something that's consistent. Now, that's a personal risk-reward decision that you need to make with yourself, with your family, and discussion with your doctor as to the pros and the cons of doing intermittent versus continuous. Some doctors may think that the ability or the whether you should do it may be reliant, may result of how aggressive your cancer is, but those are very individual conversations. I do intermittent. Now, you asked the question, does doing intermittent therapy extend how long you're going to respond before you become from castrate sensitive, in other words, responding to the hormone therapy, to castrate resistant, when you can be castrate based on the testosterone numbers, but yet your PSA still continues to go up? And the answer is, we don't know. There's no research that has been done that I'm aware of that shows that, in fact, it will extend it. I like to think that perhaps it does, but the answer is I'm not aware of any research that has answered that question. But I can tell you it improves quality of life.
Joel, two questions. You use the word castrate and castrate resistant, and they're really tough words. I think we all hate them, but can you just tell us briefly, what does it mean?
Sure. So the goal of the hormone therapy is that eliminate the production of the androgens, or basically to bring your testosterone level down from what is normal down to
less than 50.
Less than 50, but I think the better goal is actually less than 20 nanograms per milliliter.
So there's a great question to ask your doctor. There's a little bit.
Exactly.
Yeah.
So if you have testosterone level less than 50 or 20 nanograms per milliliter, which is how the test is measured, and it's a simple testosterone test. It's a simple blood test, just like a PSA, and they can draw an extra vial, and they should draw an extra vial of blood when you have your PSA, when you're on hormone therapy. I recommend that you always have your T level tested to make sure that you are castrated, because you can be on these drugs and not be castrated, you not be under that 50 nanograms per milliliter. So it's really important to make sure that you are in fact castrated.
So we use the word castrate
under that level.
For blood testosterone that's less than 50 or less than 20, and some of the experts disagree on that, but that's what castrate means. It's just a tough word. So castrate resistant means
that even though you're castrated or you're below the 50 or the 20 nanograms per milliliter, despite that, your cancer is growing, and it's as demonstrated by an increase in your PSA.
Okay.
And so that's when you want to make sure that, in fact, you're really castrated before you make a decision that you are now castrate resistant. Hopefully that clarified it.
Yeah, it's almost like saying hormone therapy or Lupron, let's say, resistant is castrate resistant. In other words, you're on the Lupron, and some of your cancer may be responding, but not all of it. That's why you stay on the Lupron and they add something else. So that would be castrate. When the PSA is going up, it's castrate resistant. When the PSA is staying down, it's castrate sensitive. So
correct.
They used to call it hormone sensitive and hormone resistant. They've called it androgen sensitive and androgen resistant. So you might find those words when you're Googling this, but that's what it means.
Question?
Yes.
Hi, I'm David. I didn't get my name up there.
Hi, David.
In the last webinar, it was indicated that besides getting the PSA and the testosterone test, it's also good to get a DRE. Now, I've been in remission for approximately 4 years, and none of my urologists have done a DRE since.
Okay, so let me pause you for just a minute. The last webinar was for newly diagnosed patients, right? So it doesn't
maybe it was 2B4.
Okay, yeah. So just to be clear, it might have been a different group of prostate cancer patients. But yeah, and I'll let Joel comment on that, whether you should continue a DRE through your prostate cancer care when you're on hormone therapy.
Thank you.
You're welcome.
It's an excellent question, and I will say that in my experience, In the 13 years that I have been on hormone therapy, intermittent hormone therapy, I think that I've actually had 3 DREs over the time. At some point, my oncologist and I will say, well, maybe it's time to do one. I think what's, especially I've had surgery. So theoretically, he should feel or she should feel nothing when they do a DRE. I think that they just want to make sure they continue to feel nothing, especially if you have lymph nodes nearby the prostate bed. So I think it's a question that you should ask your doc.
Yes.
I can tell you that most men that I'm aware of don't have regular DREs at this stage. I'm not sure what's the best practice, though. I think that's a question to ask your doctor.
And let me just state, DRE is digital rectal exam. It's what the urologist does when you're screening and after you're diagnosed, and it's part of. So that's what DRE is. It's a great question. Urologists probably do it best, but it's certainly something you can ask your doctor if you think that matters to you, if that's something that you want to check.
And by the way, a medical oncologist who I think many of us will have moved on to if we're at the point that we're talking about, if you have metastatic or advanced prostate cancer, they are quite capable of doing DREs, and they can do it. They just don't do as many as urologists. So, that is a factor.
Okay, I've got a question from Jerry. He says, do we know that if the second step after ADT, that's hormone therapy, radiation therapy itself, compromises the immune system? Jerry, I'm not sure I know what the second step is, because if you're talking about hormone therapy or ADT plus radiation, step 1 is hormone therapy, step 2 is radiation, and that goes on for quite a while. So
that's the second step I meant.
The radiation.
That is the second step I meant.
Gotcha. Do you mean the radiation?
Correct.
Okay. I don't know the answer to that. That's a great question.
Okay.
Ask your radiation oncologist, not the urologist.
I certainly intend on it.
Yeah.
But okay. Thank you.
I have 2 thoughts on that based on things that I've read or heard over 18 years I've been doing this. One is that there's some radiation where they talk about the immune system being boosted. There's something called an abscopal effect. And I've seen that before. It's ABCSOPAL. But then there's other things I've read that talk about radiation can be difficult on some of the blood counts. So it could make a difference to where you're radiating, what you're radiating. For example, if you're radiating the spine because you have metastasis, that can drop your blood counts. One small spot, obviously, probably not, but a lot of radiation to the spine or to other bones can do a number on your bone marrow a little bit. So it's always something you want to watch. But radiation to the prostate would be different, I would think. Yes.
Jan, the reason I asked the question is because as I've been led to believe that many folks who choose the option of radiation treatment usually start with ADT. That's why, I mean, since if in fact it starts with ADT 3 months down the road or 4 months down the road or some point down the road, which C19, COVID-19 is still going to be around, it's a relevant question because we know that radiation treatment's coming.
Right. So it's possible it might boost your immune system. I don't know. Great question.
Yeah. Okay.
So
I'll ask the question. Thank you.
Right.
Okay.
I absolutely agree with what Jan said, but during COVID, one of the issues are if you have radiation, you're going to be needing to go into the hospital, which can increase your exposure to potential virus infection, and you can go a number of times. So that is a factor that you need to think about.
So let me address that because they are actually. So NCCN. Let's talk about some COVID-19 guidelines for prostate cancer treatment while we're going through this pandemic of coronavirus. NCCN issues guidelines for virtually everything in prostate cancer, and it's a group, as you can see, of 28 top institutions in the United States. And, everybody's wondering what's different because of this pandemic, coronavirus. So they issued some guidelines during coronavirus, somewhere around April 1st or 2nd. I didn't see them till last week. But one of the things that they're talking about regularly is what Tanya Dorff addressed in the video, which is less visits to the clinic, less person-to-person contact, less time interacting with other people, so you can do more isolation till we get through this pandemic, whenever that is. So if you're doing radiation, one of the things they are recommending is that you consider something called SBRT, or hypofractionated. And that simply means your radiation therapy would be something like 4 or 5 visits as opposed to 30 or 40. That's in here somewhere. I'm probably not going to find it. So in simple terms, I would look up CyberKnife, CYBERKNIFE. Now there's other methods to do the shorter radiation. CyberKnife is one brand, and it's the most research technique. So that is a recommendation right now with radiation. To have to go in like 5 weeks in a row, and
Thank you.
You're very welcome. So I would look for research CyberKnife and ask the radiation oncologist about that. The word,
Yes, I will.
Yeah, hypofractionated. Sorry about that. It's HYPO. Hypo just means less of. It's the opposite of hyper, which means more of. Fractionated, a fraction is just each visit to the clinic to get a radiation treatment. So less visits, less fractions. Hypofractionated is what they're recommending during coronavirus.
Thank you. I'll turn off my mic.
You're very welcome. Happy to help. Okay, we've got another question. Randy, what is the risk? We talk about risk and benefit, Joel, right? So what is the risk to intermittent? So Joel, can you talk about your personal risks and benefits that you weighed out? And one question I would throw in there is if you are metastatic or if you are castrate resistant, nobody's probably going to suggest intermittent. The risk is going to be too great. Correct, Joel?
I would agree. I think the big risk is, will it affect how long I'm going to live, my survival with prostate cancer? Now, obviously, if I die of something that's unrelated, I go out and get hit by a car, it doesn't matter whether I'm been intermittent or not, because that's not what's going to kill me. But people do die of prostate cancer. It is actually the second biggest cancer killer in men, followed only by lung cancer. So there are significant numbers of men who do die of prostate cancer, and the question is, or the risk is, does doing intermittent, since I'm allowing the cancer to start grow again, is that in any way affecting how long I'm going to survive? And the answer is we don't know. So that's the biggest risk that one faces.
And I take back the comment I said about if you're metastatic, they may not suggest it because you're metastatic to the lymph nodes, but not the bone, which is different. And continue to respond to hormone therapy, so you're not castrate resistant. Yeah. Correct.
And even if there's metastases to the bone, if you respond, then those metastases, and the PSA goes down, and those metastases shrink, as evidenced by scans. It may well still be something that you can consider. These are very individual decisions. There's really no specific guidance.
Yes.
There isn't even guidance as to how you go off and practice intermittent hormone therapy. When do you go back on? When your PSA gets to be a certain number, what's that number? There are no rules. What about scans? Is there progression on the scans? And how much progression? And there are no rules, there are no guidelines, and there you have to rely on how much risk you're willing to take. I would imagine the higher your PSA, or the more progression, or the less lack of progression may put you at a higher risk. And that's something that you got to think about yourself. How risk tolerant are you? And that's a good time also to have a discussion with your doctor to see where they're at. And that's why it's really important to be with an experienced doctor who treats a lot of prostate cancer, if not exclusively, because they have they see many more people, they see many different types of responses. And I also think it's an appropriate conversation to have with your family, particularly your spouse, if you have a spouse, or your partner, because how long you live and so forth also affects them. And I think these are conversations, and we need to have conversations with a lot of different people and figure out how we feel about it ourselves. It's a very personal decision.
So got another question from Randy. Randy, maybe you want to turn your mic on. She said, we have never been above less than 0. So I'm going to assume that means my husband's PSA is less than.
Yeah, we're a team.
I know. I felt the same way. Since surgery and radiation 7.5 years ago, remind me, is your husband currently on hormone therapy like Lupron?
I dropped it for like I think now it's like 6 months instead of doing it every 3 months. And the Casedex, I dropped it instead of every day to once every 5 days. And I do it on my own because, you know, I'm just trying to see what. And Joel, I appreciate what you're saying because, you know, I'm learning a lot from this session.
Good.
So, you know, I want to learn more. I want to know what's happening with other people. When you stop it, what happened?
So, when you stop, what happens with you, Joel?
So when I stop, what happens with me is my PSA, you know, eventually will start to go back up again. And if I have a scan, we'll start seeing changes or growth or, you know, that the lymph nodes that we have identified will start to grow. And those are clearly the prostate cancer, or, you know, that we've been able to identify. I'm going to urge you, if you're going to change your medications, that's a very personal thing and you're going to play with it, but please let your doctor know you're doing that. Okay, it's really important. It's your decision and your right to take something or not take something, to skip something, but you're not doing yourself service if you don't at least let your doctor know.
Thank you.
You're welcome.
I will
go ahead.
Just one second.
Yeah.
I will go this week and do the PSA test again. And, you know, I think it's like 4 or 5 months since I did it, and see what happened. And I will talk to him. That's a good advice, and I take it to heart. I will talk to him.
I would ask the doctor for 2 tests. Number 1, a PSA blood test. Number 2, a testosterone blood test.
Yes.
Because
yes.
correlate. Yeah.
From your notes.
Yeah, and yeah, the second point I want to make is, you know, we talk about every cancer is different, like, right? So you're asking Joel about his experience with intermittent hormone therapy. So let's talk about how your cancer and Joel's cancer might be different or similar. So if I remember right, Joel's Gleason score was 7. Is that right, Joel?
That is correct. It was a 3 plus 4.
And what was yours?
9.
9. So there's one difference, okay? And remember that Gleason score does measure aggressiveness of cancer. So yours is going to be more aggressive in nature. So just keep that in mind. My husband's Gleason was also 9. All right? Remember, 13 years, you know, we did the metastatic journey, or he did. So what else? Do you have you ever had imaging, Randy, that says that there's a metastasis to your bone or your lymph nodes?
You know, in the very beginning, and that's why they put me on the medicine no, in matter of fact, no, because they told me the medicine is to prevent from anything else to come on. And that was from the very beginning.
Have you ever had an Axumin PET scan, AXUMIN?
No, that I know of, no.
If you've had treatment and your PSA is rising, Medicare would pay for an Axumin PET scan.
Okay, it's not rising.
Okay.
I'll know in a few days.
But Randy, if you're not testing it, you know, you don't know if it's rising, right?
Oh, he was every month.
I was doing it. Yeah, I was doing it. You know, every 30 days, every 35 days,
Okay.
And then I dropped it because everything, you know, I mean, it was 0. So
yeah,
and
I gotcha. Thanks.
then when I did every 3 months for several years, it was 0. So
Okay.
Really undetectable.
Okay.
I just have one
You
more.
can only have one session running.
When you say eventually, my PSA eventually went up. What does eventually mean?
1 year, 2 years, 3 years. Joel.
Was that question directed to me?
I think,
Yes.
yeah.
Yes.
Oh,
There
okay.
it is.
So I've gone
There it
on
is.
and off a number of times during the course of the 13 years. One thing about my prostate cancer, it is very sensitive to hormone therapy. So when I go on hormone therapy, and I've been using Lupron and Casodex, and I actually stay on Casodex. I take it a week or two before I get my Lupron or Eligard shot, and then I take Casodex and then I get my injection, and I actually stay on the Casodex during the whole time I'm on Lupron. That's how I've been doing it. My PSA drops very quickly once I get the Lupron shot, and I go into the hundredths. So that means my PSA is 0.0 something, not tenths but hundredths, and then I will stay that way and each time what I've been doing is I've been shrinking how long the timing that I stay on the hormone therapy. Originally, first round I stayed on for 16 months, and then I'm now staying on 9 months, and I would personally. And again, this is very personal. This is me. I'm not saying it's right. I'm not, advising anyone to do this. But I've stayed on 9 months, and the reason I've stayed on that long is because I do have identifiable metastases, and they do change. So my PSA, each time I go back on, go back off, I look at what's called the PSA doubling time, and that's how quickly my PSA changes or doubles in numbers, like doubling being 2 to 4, 4 to 8, 8 to 16. That's what doubling means. And what I find that each time I go off therapy, my doubling time is different. So I usually it's less than 1 year, and the shorter my doubling time. So the last time I was off, I was doubling every 3 months, every 90 days. So I didn't stay off as long. I went back on sooner. So instead of having a PSA that was 6, I went back on at 3 because I was concerned at how quickly it was doubling. But that's an individual thing. And as I said, there's no rules on how you do this. There's no guidelines saying you should go back on when your PSA hits a certain number, and you should stay on for a certain amount of time, and you stay off for a certain amount of time. And that's why a lot of the research as to one being better than the other isn't particularly helpful, because men practice intermittent hormone therapy in very different ways. And when they do the research, they create a protocol. And that protocol is not often reflective of how it really gets practiced. Was that
question for Joel?
Complex?
Question for Joel.
Sure, go ahead, David.
Joel, obviously there's a plethora of side effects from being on ADT. So the question is, going off of it and going to intermittent, just how much of a recovery from things like hot flashes, regaining strength and muscularity, mood, things like that, how quickly and to what extent does it actually go back to its previous level?
So there's a lot of different, first of all, it's not consistent from one man to another. And my own experience is it's not consistent from each time I go back on and go back off. It's different. There are factors, I think, that might influence how quickly you recover. And basically what's happening by going off the therapy, your body is able to recover, start making the testosterone again, that if the Lupron is prevented, and if you're taking some of the blocking drugs, and those androgens you're making are allowed to get into the cells and do their thing, not only with the cancer but with the rest of your body. And how quickly you recover is a very different thing from one man to another. I do believe that the older you are, the recovery tends to take a little longer. But I have found that I will recover sometimes more quickly than other times. So I can't predict it, and it's very individual. So I can't give you guidance beyond that. But I will say that normally I begin feeling better within 2 to 3 months. But even increments make you feel better.
Mhm. Well, the one specific question is, those of us who are on ADTs, we have a greater risk of osteoporosis, and a couple years after I was on it, I became osteopenic.
Mm-hmm.
So the question is, I do things like here in Florida, we have the bone builders exercises in the villages, which presumably minimize the risk, or at least keep things under control. So I'm just wondering if really being in the intermittent, if that would really kind of better control the osteoporosis risk.
I hope that it does, and that's one of my goals.
Mm-hmm.
Again, the research with intermittent is pretty spotty at best, and I don't know that and I'm not saying there isn't. I'm just not aware of actual research that shows that it delays it. I believe that it may well. I believe so. For instance, we have weight gain when we're on hormone therapy. That's a common side effect. And most of the weight gain tends to be in the middle, which is the worst place it can be for our heart health. And I work very hard, and sometimes more successfully than other times when I'm on an off stage. I first, even when I'm on, I try not to gain weight, but I always do. And sometimes I've gained dramatic amounts of weight, 20, 25 pounds. I try very hard on the off period, and it's a lot easier to begin to lose some of that weight. And I, and of course, it is important to continue doing exercise, both anaerobic and aerobic exercise, to try to maintain muscle mass. My own experience with muscle mass, I've never been able to regain muscle mass. That's me. I think there are some guys who do. There's some guys who were able to do a lot of exercise even through their ADT experience, and there are others of us who just can't. Now, you also have to look at other comorbidities. I have some autoimmune illness, arthritic type condition, and so I do suffer some other pains and discomforts, and that makes it harder to exercise or do the kind of exercise I should do. So these are very individual. I don't believe that doing intermittent is going to hurt your bones. It might help your bones, but I don't have any evidence to that fact.
Very helpful and thorough answer. Thank you so much.
I would say that if you have osteopenia, let me think for just a minute. Did you say that you're currently doing intermittent?
No, I'm on continuous for 4 years.
Got
I was stage 4 with a very high Gleason score, and I was 75 at the time.
PSA.
So they did not do a surgical removal. They just did shrinkage prior to 44 radiations.
So you were age 75 at the time?
Yes, I'm 78 now.
When you say stage 4, that means they found metastasis, so they found
one spot on the sacrum, which seemingly has disappeared according to various radiological tests.
Okay, are you still with a urologist, or are you seeing a medical oncologist?
I also see a medical oncologist at the University of Maryland, and looking for one in Florida, which I have my first appointment with in a couple of weeks.
So here's my question. If you're on hormone therapy and you have a documented metastasis, has anyone talked to you about a short needle shot called Xgeva or Prolia?
Yes, but they said at this stage, the side effects may not be worth it. I don't have any other comorbidity issues.
Okay.
So at this stage, yes, it's been discussed.
I would ask them which side effects they're talking about. And then you can call me if you want. We can discuss that. But being age 75 and on hormone therapy and osteopenia, preserving your bone density is important. So
yeah, thank you very much.
Which side effects are they talking about? Make them be specific for you.
I can't recall.
Yeah. Also,
I can't recall the specifics.
Well, I'm just saying, ask them next time you go in. I have a feeling I know what it is, and I could help you with that possibly.
Thank you very much.
You're welcome.
Yeah. So when you make the decision to do intermittent versus continuous, I think that there are a number of factors that you need to discuss with your doctor, and that includes how aggressive your cancer is, which is measured by your Gleason score. And I don't really know of guys who have Gleason 9 or 10s that are doing intermittents. I can tell you personally, if I had a Gleason 9 or 10, I was a Gleason 3+4, I wouldn't do it. But that's a personal decision, and it's a medical decision that you need to talk to your doctor about.
Any other questions? So some people haven't asked. Anybody have a doctor's appointment coming up that you would like help developing the questions? Anybody have a side effect that's really bothering them or a treatment decision to make?
Jan,
Hey, Jan.
Jan.
Oh, good.
I got two people. So Jerry, you want to go, and then Dennis go second?
Okay.
Okay.
Yeah, I was on the call the other day, so I've either got a face-to-face appointment with the doctor on May 4th, or likely a telemedicine appointment with him.
I would say likely.
And so I've started to, yes, and I've started to develop some questions that were that emanated from the last newly diagnosed seminar.
Okay.
Regarding the size of my prostate, which I haven't an idea for. So I was starting to put together some questions, and so whatever you might suggest, I certainly have learned something from this call, which will cause me to ask him, about risks and about what drug he may be using and thinking about using, et cetera, et cetera. But
okay.
So I'm on the very early stages of putting together that list of questions.
Okay, and you can also call me later, but I think asking about prostate size, and again, you're newly diagnosed and making treatment decision.
Correct.
Yeah, it is definitely one that tends to get overlooked. Is always a good question when considering radiation. So
yeah, can I email either of you with the questions that I'm going to ask,
yes,
so that you may suggest some others?
Email both of us, and we'll
Thank
both comment. You're welcome. Dennis,
thank you.
How are you doing?
Yeah,
what did you have?
Yeah. We're just, I'm just getting started with the Lupron, so I have a couple of things. Initially, I had maybe 2-3 months ago, I had a bone scan and a CT scan, and nothing shows up.
Right.
So the doc's assessment is there's very little cancer in there, but for some reason the PSA is doubling too fast, like a little over a month.
Okay.
So initially they decide. I see you made a face, Joel. That's not good. But so initially they decided to add Lupron with something else to knock it down. But then they decided just start with the Lupron to see how that works. Now, prior to doing the Firmagon, the PSA was not doubling that fast, and it went to 0 with the Firmagon. Then we stopped it, and then it started to double a little faster. So, and I also had a 3 and a 4, 3 plus 4 like Joel. So
a Gleason of 3 plus 4 equals 7.
Right. So, I mean, with that being said, and I don't do Casodex anymore. I don't know if I should suggest that to the doc, but at this stage, with nothing showing up, the way they described it to me is just a lot of little microscopic cells, ants crawling around, and they just want to take care of the PSA. That's what's your response to that attitude?
So first of all, you have to understand that our scanning technology has significant limitations, and it takes millions and millions and millions of cells in one place for current scanning to be able to see that. So did you say what your treatment has been to date besides the Firmagon? Did you have surgery or radiation? I don't remember.
Yes, for a while ago. My initial surgery was in 2011
You had surgery. Okay.
for the prostatectomy, and it went, PSA was 0 for 5 years.
Right. Okay. So that means that you, like with me, somewhere along the line, there's cells that escape the prostate gland, or there's been tissue left behind, whatever it is, and that it's floating around. I often thought of, my illusion about my cancer until we started seeing the lymph nodes, which initially the first few years we didn't see anything. I had negative scans, is I had fairy dust, or someone else said no, not fairy dust, devil dust, kind of floating around in me. That was always my illusion. But I mean, clearly there's cancer cells there, because that's what the PSA is that's why you have a PSA. The question is, you just can't find it because your scans have been negative. But you do have it. It's there somewhere. And a doubling time of 1 month is pretty significant.
It's concerning.
Yeah, it's very concerning, honestly. And so you want to make sure you do stay on top of it. And it may well, just Lupron alone might well deal with it for a period of time. You don't know. You have to give it a try and see. It's really important, especially with a doubling time of 1 month, that you do very aggressive monitoring of your PSA, and perhaps even scans if you can get it approved for insurance purposes, but certainly PSA, so that you track to make sure that whatever the treatment you're doing, be it Lupron or Lupron and Casodex or Firmagon or any of the other drugs, that you're becoming castrate. In other words, you get your testosterone below that. My hope is 20 nanograms per milliliter, but docs sometimes say 50 is adequate. And the lower you get it, the better you're going to be. And you want to make sure that you get it down there, and you want to then see that PSA is controlled. And it may well require a PSA test with a doubling time of once a month, a PSA test of at least once a month, until at least you become more comfortable that you're controlling it.
Right. Well, that's what it is. And in terms of the scans, I've done the Axumin scan in the past.
Okay.
And that was prior to that PSMA I spoke about.
Okay.
And they actually found one spot that was outside the bed, and I had a PLND, a pelvic lymph node dissection. They did that.
Yeah.
Okay.
They couldn't find it. They took out 20 lymph nodes, and they were all good, and they missed the bad one.
Oh, I can't tell you how many times that happens. There's so many lymph nodes. It's mind-boggling, and it can be hard to pinpoint it. And some surgeons are better than others.
Yeah. But, the other thing is you can actually radiate that lymph node if they can find it again.
Yeah.
Well, I've got 2 good people who are working with me, but my question is a little bit morbid, but what is it with all of these medications? What is it that kills people with prostate cancer? Because it seems like there's always something, like immunotherapy seems like it's something coming down the road, which could be helpful and effective.
Can I answer that?
Be my guest.
I'm probably going to argue that, again, one of the most powerful things is staying involved in your care. That's not always the reason, but that is the reason that my husband lived longer. So I would start there. And the reason I like that message is because it's empowering. I'm not taking anything away from anyone. I'm not exaggerating, and I'm just stating, the facts. So I do believe that staying involved in your care extends your life, period. So I'll do it that way. Sometimes treatments are given to patients, and the risk and benefit isn't really, how do I say this? Sometimes there's too much risk. And I find, so here's something that I learned in the clinic, working doctor's appointments. I find in general, doctors have a tendency, and I apologize for the stereotype, to talk about a treatment's benefit. Okay? When they do talk about the risk, which is side effects, they have a tendency to rattle it off. It's a little bit like a laundry list, like they have to tell you. but it's, I know they're required to do it, but I could never understand what they were saying. Everything came off the same. Nausea and heart attack went in the same sentence, and there was no pause. And I was just like, what are you talking about? Heart attack potential. Yeah. So that's not really helpful. So what I started telling my callers to do, talk to the doctor about the treatment, the benefit, talk to the nurse about the side effects. And somehow that helps. But I definitely have seen people who were given too much treatment and they ended up with side effects that could be really difficult and even deadly, So I would always encourage people to ask your nurse about the side effects. One example would be chemotherapy and the man gets pneumonia. That's one example. So there's a pneumonia vaccine. Did you have your pneumonia vaccine? There's, monitoring those white blood cell counts, keeping your own copies of your own blood work so that you know what's going on, not letting your platelets get too low. Talk to the nurse. Preventing the side effects. I have a really short presentation I do on preventing chemotherapy side effects. So as you get into further treatments, ask more about the side effects so they don't become life-threatening, to be really honest. Ask about how I can prevent them. And if the side effects are too much and you feel like you need a break from that treatment, you start that conversation. Don't hesitate. That is shared decision making. So that's one thing, a problem that I've seen in prostate cancer care.
So I tend to be a very literal person, and so I listen to what I think your question is, and maybe I'm missing this, but I think you asked how people die from prostate cancer. Did I hear that correctly?
Right, yeah. With all of the medications and the immunotherapy and everything else.
Yeah. Okay, so one dies from prostate cancer usually because the prostate cancer somehow impacts and some organ in the body that then causes your death. It could be the heart, it could be the aorta, it could be the liver, but that's, I think, my understanding is what actually leads to the death. It's not the cancer, but what the cancer does to organs in your body. So I don't know if that answers the question.
Or the treatment, because prostate cancer doesn't go to the heart, right?
Yeah, the treatment can also affect it. That's a good point. Thank you, Jan. Now, the other thing I want to know is we didn't really discuss genetics and genetic testing at all during this conversation.
Oh, do we really want to get into that now? We're an hour and a half.
I'm going to urge that we're doing a genetics session next week.
Yes.
On what day, Jan? Tuesday?
Yeah, Thursday, April 30th at 2:00. Yes.
Right. So genetics are, I'm not going to get into the particulars, but genetics are really important because it gives us a lot of insight into treatments and responses. And it's something that's really important for guys with metastatic prostate cancer or PSA rising, after treatment. And I'm going to urge that you tune into that because that's going to be very informative. And I'm going to leave it at that. And I'm also going to comment on what you asked about immunotherapy. Basically, prostate cancer is considered to be fairly a desert when it comes to immunotherapy compared to other treatments, other cancers rather. We do have one treatment called Provenge or stipple cell T, which is effective. It does extend life for prostate cancer. The best time, and I'm going to urge that people go to the blog on the Advanced Prostate Cancer blog on Cancer ABCs, and you can search for Provenge. You're going to see a lot of articles about it. I'm not going to repeat them, but basically Provenge should be taken early on. As soon as you become castrate resistant, that's the best time to take it when your PSA is lower. The survival benefit is much better. There are other immunotherapies available, and they're not approved, however, for prostate cancer. But increasingly, we're doing research to find that they may work. This is very much in clinical trials. It's something that, again, to talk to your doctor about. And again, Dr. Chuck Drake will be with us a week from Friday, talking very specifically about immunotherapy and prostate cancer. So I also urge you to go into that because we just don't have the time at this point. But genetics and immunotherapy are really important topics for people who are in the position that we're in, and that's having a rising PSA after treatment.
Good point, Joel. Those are 2 webinars next week. Check your email because you've already received an email from me about it, but I'll send out another one next week. So we're at an hour and a half into the webinar, so I think I'm going to close it out, but people can still email us. Let me just check the comments one more time. Make sure no new comments. So, and we're still working on webinars to help address some of these issues like we originally had planned for the conference in the villages. So that's it. Thank you, everyone. This is Cancer ABCs, and
What's the email? What's the email, Jen?
it's jan@cancerabcs.org,
Okay.
and then it's joel@cancerabcs.org.
When you send the email, make sure it's ABCS. It's plural, like know your ABCs, okay?
Yeah.
Because sometimes people don't put that S in and we never get it.
Yep.
Thank you very much, guys.
You're welcome. You're very welcome.
It was
Thank you.
very
Bye, everyone. Stay safe. Social distance. Wash your hands.
Papa Joel. All right. Thanks,
Bye-bye.
Bye.
everybody.